Okay, well, we're going to go through toxicology, at least try to get through part 3. So we'll probably be another portion of this. We'll probably finish everything up on Wednesday, the 5th. So you wanted to finish up with some of the stuff that we didn't finish on this last Wednesday. So some specific toxins that we did not hit on were hydrofluoric acid. So this is a very toxic, extremely lethal type of acid burn. So despite the moderate burns on the skin and contact, it can be very, very lethal. It penetrates deeply into tissue and is inactivated only when it comes into contact with stuff like calcium. So remove the calcium from the cells causes disruption of cell function. So of course, once we don't have calcium flowing in and out, think about cardiac tissue and anything else that don't have calcium, and we have trouble. So we have trouble with all different kinds of things. So it can even cause some bone destruction as the calcium's leached out of the bones if it gets into that portion. So the death has been reported from exposures up to less than 2.5% of body surface area. So only that little bit of surface area can cause lethal doses of this stuff if it goes too far. Some of the signs and symptoms show a burning at the site of contact, trouble breathing, confusion, palpitations, muscle cramps. So you can kind of see why disruption of calcium can cause a lot of those different problems for you. If you look at the burn on the palm, so the palm, he's got a small burn on the palm of his hand. So palm of the hand is really a bad spot anyway to get burns. If you burn that 1% body surface area of your hand, that the palm is 1%. So if that whole hand was burned, that's 1%. If he burned both of his hands and part of his fingers on both hands with this stuff, he'd have had that 2.5%. He's in trouble and needed to go somewhere. So what do we want to take care of these guys? So we want to make sure that we have, make sure that you're safe first. Safety first. There you go. Scene safe, scene safe. That's all about you because you don't have the equipment to deal with that. Initiate supportive measures, so keep him supported, ABCs, remove exposed clothing, thoroughly irrigate the affected area with water, okay? If you can, immerse the affected limb in ice water with maybe a little magnesium, calcium salts, some of that stuff. You need to send him definitely someplace where he can go and get definitive care. So that's some of the other things you can do with him, the hydrofluoric acid. And that's really, like I said, it's really nasty. So you need to make sure you're on board with that and know what that's all about. So next thing I want to talk about some hydrocarbons. So hydrocarbons are basically carbon-based organic material compounds. When we say carbon organic compounds, we're talking about carbon and hydrogen. Carbon-based, oh God, old Star Trek thing. Carbon-based life form. Okay, there you go. So, but we have stuff like this. So hydrocarbons come off of things like kerosene, turpentine, mineral oil, chloroform, toluene. We don't see that in a lot of places, but there's a lot of places where that's at in the industrial areas, in benzenes. Where do we find hydrocarbons? Lighter fluid, paint, glue, solvents, lubricants, aerosol propellants have this stuff in them. So how do we get it? We can get it by ingestion, inhalation, and surface absorption. So pretty much every little way you can think of. I suppose you can inject it too, but that would be a little more difficult. Most people don't do that. These are the usual routes of admission into the body. So what are my signs and symptoms? What my signs and symptoms are, of course, the burns at the local contact area. If we inhale it, so we start having wheezing and dyspnea, start getting hypoxic. Might get some pneumonitis if we aspirate it or inhale it too much. We might actually get a little pneumonitis from that. Inflammation of the lungs from that. CNS-wise, man, look at this. Headaches, dizziness, slurred speech, ataxia. You become obtunded. Obtunded, it's a great word. Look it up and see if you can find a picture of it. It gives you a whole look at it, what happens. You guys remember how I looked the other day for the medical scenario when I finally start going out of it, and I'm just like looking out, but I'm not seeing anything. I mean, that's obtunded. Foot and wrist drop. Isn't that weird? But you might get some of that from hydrocarbon toxicity. Numbness and tingling and foot and wrist drop. And of course, look at this cardiac dysrhythmia thing. That's not that's nasty. You need to manage those. So less than 1% actually need any intervention for us Charcoal will not bind hydrocarbons, so one of the few cases in which gastric lavage is useful. So that's if you swallow it. I mean, and they probably won't even give you won't give you activated charcoal for that because it just really isn't that indicative. It doesn't do much for you. Okay. So now to hear some tricyclic antidepressants. So here's some toxins that we start thinking about. There might be not. There's other antidepressants, but people are still on these tricyclic antidepressants. There's a very small therapeutic index, so your blood levels are just a very narrow window for that. So they're kind of hard to manage. That's part of the problem with them. So they quickly lead to toxic effects because a lot of times we go out of the therapeutic level. Okay. May be responsible for more deaths due to intentional overdose than any other medication we have. Isn't that crazy? But we still use them for a lot of things. So, what kind of things are they? Let's see. Some medications you might think about if you see somebody on medications like Elavil or amitriptyline, amoxapine, doxepin, imipramine, nortriptyline. So those leans and pins, leans and pins are kind of like some of those medications that might clue you into that they're on a tricyclic antidepressant. First of all, you'll see that in their history that they are on antidepressants. They might not know what they are, but here's a list of some of them that you might see. Of course, we just talked about them. And signs and symptoms that were out of therapeutic level and toxic are dry mouth, blurred vision, urinary retention, and constipation can be some of the things they're complaining of. If you get some more severe kind of things, so now you start getting severe toxicity where you guys are probably going to be getting called for, is hallucinations, become hypothermic. They go respiratory and seizures, respiratory depression. So once again, you're going to have to support your ABCs is what you're really working for. And you can see some of the different effects you're going to have CNS-wise and seizures, all the way to seizures and basically altered mental status, tachycardia with hypotension, and cardiac dysrhythmias. A lot of times you'll see heart blocks and wide QRS complexes, dysrhythmias, or maybe even torsades with some of these guys. So we really want to start standard procedures that we use initially. Cardiac monitor. The arrhythmias is the most common cause of death. So going into a heart block or a wide QRS tachycardia or torsades is probably one of the most common. It is the most common cause for somebody to go into arrest with these toxicity to tricyclics. If you have a suspected mixed overdose, like you have benzodiazepines, so some of these guys might be on benzos too for depression or anxiety, and they're on a tricyclic. If you think you have two of those, don't use romazicon or flumazenil, same thing. That's like a reversal agent, just like Narcan is for opiates. And that's only for benzodiazepines. But if you have that mixed with the tricyclic, they don't want you to use that. We don't carry that too much anymore because a lot of times coming out of things is just, I don't know. Big deal is coming out of that and we use that, the guy starts having seizures. So there you go. So we don't want to do that. It may precipitate some cardiac problems too. So some of the things that the treatment, there's an algorithm you can see in your book. It lists some of the tricyclic antidepressants. So you're looking for evidence of it, an ingestion, get the poison center, do not make them throw up, monitor IV O2. If they're hypotensive, we can maybe give them a fluid bolus. We definitely want to get a 12 lead on them if they're hypotensive. The QRS is got a lengthened, a widening QRS. We could consider even thinking about bicarbonate therapy if it's in your protocols. And if it's not widened, then we can just transport and monitor those patients. But once again, look at those wide complex tachycardias and torsades. We got to treat those dysrhythmias as we see them, right? So always just follow your medical control and you'll be good. So MAO inhibitors, you see them all the time. Don't use with MAO inhibitors. So that's monoamine oxidase inhibitors used to treat depression and obsessive compulsive disorders. So you might see some people that are on some of those things for obsessive compulsive behaviors and disorders. There's a very narrow therapeutic index with these two. So it has interactions between other drugs, and they may be on other medications for other neurologic or psychiatric problems. They really interact with certain foods, especially ones containing tyramine. Okay? So where do we find tyramine at? We find tyramine in what? Isn't that what we find? Oh, I'm sorry. I'm getting it confused with tryptophan. Excuse me. All right, so we want to go ahead and watch it. So there's a very high morbidity, mortality with overdoses of MAO inhibitors. So it's a big deal. All right. What these do is they inhibit the breakdown of the neurotransmitters like epi and norepinephrine and dopamine in the neurotransmitter in the synaptic cleft. So without that breakdown of these things, so they can be reabsorbed in their components back in and become inefficient, it increases the amounts of epi and norepinephrine in the neurotransmitters. So it really screws up your level of synaptic activation, because you have so much buildup of epi and norepinephrine, because the MAO slows that breakdown of that enzyme to break down epi and norepinephrine for reuptake and reuse to make it more into the synaptic, presynaptic areas. So, and tell you what, some of those are that's really going to screw up your behavior and your neural functions. So signs and symptoms are going to be stuff like you're going to have headache, agitation, very restless, tremoring. So those are all CNS things, okay? May precipitate nausea because of some of the headache and agitation things. You may see some palpitations and tachycardia. Start seeing some severe hypertension going along with that. Hyperthermia. So hyperthermia, where do you see that? That would be something that would stick out in my mind, along with headache, agitation, and a history of MAO use for antidepressants, and then I see hyperthermia and palpitations and headache. I'm starting to start going with a MAO overdose. When it gets down to the point where it's really breaking everything out, you get to the point where you can't keep things up. You start seeing them go into bradycardia. That brings you down into hypotension, and from there, you see as it spirals down into coma and death. Okay, so what do we want to do for that? There is no antidote for an overdose. So we use standard toxicological things. We just use the standard stuff. All right, the standard procedures, ABCs, monitor them, try to see what else we can use, and give whatever symptoms are portraying, like seizures, treat them for seizures. If they're hyperthermic, we want to try to maybe give them some benzodiazepines to slow their tremoring down so they're not hyperthermic anymore. Okay, that'll slow some of those tremors down. If you need vasopressors, they say go ahead and use the norepinephrine. So what do we have with the problem with that? So it inhibits the breakdown of norepinephrine. So if it gets to the point where we increases the availability of those components, but you can see if vasopressors are needed, they want you to go ahead and use the norepinephrine to give that support if it gets to the point where you're hypotensive. So in recent years, we have a few newer ones. We got stuff like trazodone or Deseril. You've probably heard of that. Bupropion or Wellbutrin, and then some selective serotonin reuptake. So SSRIs, we talked about them in pharmacology. Please look that up. What they do are all those reuptake of serotonin, and it inhibits the reuptake of serotonin, so it leaves more serotonin in the neurotransmitter to be used. So that's stuff like Prozac and Luvox, Paxil, Zoloft, Prozac. You see those look very familiar. Those are newer antidepressants. The signs and symptoms of them are a little bit more mild, okay? So that's a kind of a good thing about using them. Deaths are rare, only with other mixed overdoses with multiple ingestions of other medications they may also have evidence for. So, signs and symptoms you might see for some of these overdoses are drowsiness, of course, and tremors, nausea and vomiting, and sinus tachycardia. So, once again, you use your histories to find out if they're on some of this stuff or not, to see if it's something you're using. Now, there's such a thing with the serotonin syndrome, so we have some of that overdosing on SSRIs. And what we might see for some of that, there's a autonomic instability. You have altered mental, so autonomic instability is not a good thing. All right? That's autonomic functions of our brain, like breathing and blood pressure and all those kind of things. It screws some of that up because it does not reuptake. It inhibits the reuptake of serotonin in the synaptic clefts and stuff in the neurotransmission area. So we have altered mental status, seizures, extrapyramidal syndromes, right? Muscle rigidity. There's a hyperthermia again, okay, because of some of these shaking and extrapyramidal effects. So we have that excess stimulation of serotonin receptors in the nervous system because it's being the reuptake of that is being inhibited. So drug interactions are complex. So some of those other drugs may actually manifest themselves and implicate themselves with having going into the syndrome, may activate things and make them more proliferant. So some mild symptoms would be tachycardia, shivering. Shivering can lead to that hyperthermia. Okay, sweating. Eyes are extremely tearful and wetting. Intermittent tremors or myoclonus. So the clonus, your claw hands and all that kind of stuff in feet. And then you may also be have overactive or hyperactive reflexes. So if you did a reflex test on somebody and they're on this stuff and they're showing you some of those signs and symptoms, and you pick their knee up or their elbow up and you do a reflex tap with it, and they'll overjump, they'll overreact on that jump. All right. Moderate symptoms include stuff as hypertension and hyperthermia. So you can see how some of that has developed from some of the milder symptoms like shivering and so forth. Hyperactive bowel sounds, agitation, all those things that start in moderate levels. And more severe symptoms, when you know you really got this going, you're really thinking that this is what you have going because of what you're found on your scene with their pill bottles and so forth. Severe symptoms include hypertension, severe hypertension, and tachycardia. So it gets to the point where you have that tachycardia that leads to decreased output. There you go, start leading the shock. Agitated or excited delirium. Muscular rigidity, not good. High muscular tension. Start really getting that clonal kind of effect. You might start seeing metabolic acidosis. They might even break down some, because of the overuse of their muscles and so forth from some of this stuff, you might even have the breakdown of some of the muscle tissue caused rhabdomyolysis, seizures. The rhabdomyolysis would, lead to that renal failure. And you may even see some DIC, the disseminated intravascular coagulation. You start seeing small clotting and petechiae problems all over the place. So you start seeing that develop too. You can start really helping think some of that's coming into effect. So here's this triad of a clinical abnormality. So you'll see the cognitive effects of confusion, hypomania, okay, hallucinations, agitation, headache, your autonomic effects, shivering, sweating, fever, hypertension, and you're seeing some of those autonomic effects you can't do much about. And then the muscular or body effects of that, are their clonus and myoclonus, the hyperreflexia and tremoring. All right, use standard procedures, and then discontinue the use of that, of course, and implement other supportive measures as you need to. So there's not much else you can do with some of those things. Here's some of those you might see. Once again, we talked about Prozac, Paxil, and Zoloft. They're more common. Lexapro, you might see that. It's a little more common. Celexa, Luvox, those are all SSRI antidepressants. So that would be something you see in their history, okay? So salicylates. I'm sorry, not salicylate, but lithiums. So a lot of times people have bipolar or circular disorders. They're going to be on lithium. It's the most effective drug they found for that. That's the way it's just been. And this has been a standard treatment for years. So also the trouble with these drugs, a lot of them have this very narrow therapeutic index, so you have a tendency to go up or above or below the therapeutic levels, and you may overdose in some overdoses, but you may also have toxicity in just using that normally until you get everything figured out. So a lot of times you'll see these signs and symptoms that they're starting to become toxic. So they'll be real thirsty, you have real dry mouth. That's pretty common. I've seen a guy on lithium and actually noticed he had a lot of that. He did a lot of twitching and twitched a lot with his his eyes and around his mouth and facial areas. You have increased reflexes and tremoring once again, right? Confusion, stupor. So you start seeing more. You have different stages of mental confusion, mental and central nervous system type of signs and symptoms, like confusion, stupor, to seizures, to coma. So you'll start looking for those signs and symptoms, those muscle things, the dry mouth, nausea and vomiting, and like bradycardic and other dysrhythmias. So it shows you you might have some of that stuff going on. So you have to treat the overdose mostly with supportive measures at that point. All right. So that's basically what we're going to do for these guys when they have a little bit of toxicity with lithium. Is going to be with emergency, ABCs and supportive measures. So, like the other drug we talked about earlier, the activated charcoal doesn't bind with it, so it's not going to be any effect to give them that. We don't really give them that. It's not in our protocols for the state or anything anymore. So. That's something the ER would do probably anymore, but they won't do it either, it looks like. So salicylates, overdose. I know why would you want to overdose on aspirin, but people do. But also oil of wintergreen, you can get that in places. And sometimes the aspirin's, a lot of times, along with other like narcotics and so forth, you see them mixed with aspirin. So get too much of that and you might be overdosing on that. Some typical signs and symptoms are going to be rapid respirations and hyperthermia. Okay, so how am I going to know the difference? Well, all this stuff should start cluing you into that is overdose in the first place with that hyperthermia. Confusion, lethargy, and coma. Cardiac dysrhythmias and failure. Abdominal pain. Yeah, how bad that is on your stomach, right? With salicylates and overuse, you swallow a bottle of them, you're probably going to start throwing up, which is not a bad thing. You might have some blood in your emesis because you just ripped your stomach up because of all the salicylates you just dumped in there. Any kind of non-steroidal anti-inflammatory does that to your stomachs. And eventually you might go into pulmonary edema and go into ARDS. So that's how this is bad for overdoses. Okay, so how we take care of some of this stuff. So we want to take care of standard procedures. Activated charcoal will reduce some of the absorption, so we want to use that with overdoses of aspirin and salicylates. Look at the time of ingestion to see if it's sometime we actually want to use the charcoal, if it's too late. And then symptomatic patients, we start give them fluids. Guess what? We're gonna go ahead and try to dilute it as much as possible every way you can. If you got a really bad case of the stuff, they may need to go under dialysis to help filter some of this stuff out. So this just shows you some of your treatment of salicylate poisoning. So here you got the evidence of ingestion, contact, of course, poison control, but the hospital will do that for you usually. Consider GI decontamination, so we're like activated charcoal. Don't make them throw up, but they'll probably throw up anyway because that's got to really be nasty to swallow that much of it. Monitor IV O2, transport and monitor. That's what we can do for them. Take care of their ABCs. All right. Next thing we talk about, the other common thing is Tylenol, acetaminophen. Fever and pain, right? There's all kinds of medications that contain acetaminophen along with like cough and cold stuff. Hydrocodone, stuff like that has acetaminophen in it. So large doses of 150 milligrams per kilogram. If we give them that much, up to that much, it can be toxic and actually kill your liver off enough to result in death because it just really messes your liver up bad. What's the worst thing it does to you is mess your liver up. Okay. Signs and symptoms. So the first half hour to 24 hours, nausea, vomiting, weakness, and fatigue. And we start getting into a deeper stage of this. So after a day or up to 2 days, we start having more increased abdominal pain, decreased urine, elevated liver enzymes, because now my liver's starting to get really trashed up. After the third stage of it, after 3 to 4 days of this, I start having more and more disrupted liver dysfunction. You might see elevated levels. Your enzymes will be elevated. Your liver functions will be disrupted. You won't be detoxifying things as well. You aren't able to eliminate it because you have some decrease in urinary output. And you might start real elevated forms of ammonia levels will become elevated also, which will really impact your cerebral function and maybe put you in coma for that too. After 4 to 14 days, hopefully we have gradual recovery or progressive liver failure. So hopefully we have recovery. If it's too late and gone so far, we're gonna have liver failure. So it's either going to get better after 4 to 14 days or it's going to get worse. So hopefully we catch things in time. Standard toxicological procedures. Find the time of ingestion. So here's our antidote is mucomist. And so they'll be put on a mucomist drip. It's very effective. But we're not going to do that pre-hospital. That's something they're going to have. They'll be in the ICU and be watching them for a long time on a mucomist drip. Other non-prescription pain medications. So I said the NSAIDs, like we talked about. Any of those other things like Motrin or any of those other type of non-steroidals that we use commonly over the counter. The symptoms of toxicity for those are the headache and the ringing in the ears should tip you off for that. And actually do that with aspirin also, because that is also a NSAID. Nausea and vomiting, abdominal pain because it's rough on your GI tract. Some swelling in extremities, mild drowsiness, rash and itching if you get too much on board and become more toxic and get some allergic response to it. And then also it gets down to the point where you actually have just being a wheezing. If we start having some of those, we may actually go into pulmonary edema from some of that. Okay, we're going to skip some of this theophylline. You don't see some of that so much anymore. Some metals we might come in contact with. Lead and arsenic and mercury, they affect all kinds of enzymatic systems within our body. If we don't have enzymes doing everything in our body, we're in big trouble, because that's what makes everything happen in our bodies, enzymatic changes. So, iron, the body recognizes only small amounts on a daily basis, and they usually store those for enzyme and hemoglobin production. Excess amounts obtained from supplements. So a lot of these guys got way too much in their bodies. Excesses cause a GI injury and maybe some shock from GI injury that causes hemorrhage. All we'll see is they're just diagnosed. All we're going to find out is that they took iron supplements. Signs and symptoms are vomiting, bloody vomiting, diarrhea, abdominal pain, shock if there's too much bleeding. It also can lead to liver failure, so it's rough on that, and might see some eventual bowel scarring, obstructions, and metabolic acidosis with rapid respirations. It's essential to initiate all the procedures. Activated charcoal will not bind to the iron, so don't have to use that again. And some deferoxamine, chelating type of agent could be used for helping that, breaking things down with that. With lead and mercury, a lot of that we see in glazes and paints. Before you use it, you get too much exposure to it. You don't know it's even there before toxicity becomes apparent. Mercury comes from contaminating processes, from industrial processing. Thermometers or temperature control switches have mercury in them. Chronic and acute exposures with both metals, we can have both cases. Signs and symptoms of headache, irritability, memory disturbances, tremor and weakness, agitation, abdominal pain. You guys are getting a pretty clear pattern: headache, tremor, weakness, agitation, abdominal pain. There you go. They can cause permanent neurological injury, unfortunately, with some of these heavy metals. So activated charcoal will not bind with heavy metals. So you have to use a chelating agent once again with those. So
this animation shows the many environmental sources of lead and the ways in which lead may enter the child's body. As we zoom to the insider's view, we see the portals of entry for lead and its ultimate storage site in bone, teeth, and hair. Lead exacts its toxic effects through all body systems, but especially the brain, where it poisons key sulfhydryl enzymes. Two principal modalities of treatment involve chelation therapy, namely BAL, British anti-Lewisite or dimercaprol injections, or oral DMSA, succimer or dimercaptosuccinic acid.
Okay. All right, so we're going to continue here with contaminated foods. We have some of those paralytic shellfish poisoning syndromes. If they're not cooked correctly, you got to watch that. Respiratory arrest and standard GI symptoms are going to be some of the things you see with contaminated food. Bony fish poisonings, scramble, you have histamine poisonings, common causes of GI symptoms, nausea, vomiting, diarrhea, facial flushing, respiratory distress with some seafood poisonings, and anaphylaxis. Contaminated food, poison control, you have to get samples of the food source, and then you also see stool samples to see what kind of agent is contaminated with that you can be treated appropriately for. If you do have anaphylactic kind of reactions, we have the use of antihistamines and standard anaphylaxis and allergic reaction type of things. Poisonous plants and mushrooms. I have pamphlets that identify the toxic household plants, so you can see a lot of times you'll see if they're toxic to animals and stuff. They'll have to show you that. They'll show you that for us also. The other thing you'll see is, like I said, you'll be able to see that in Poison Control Center pamphlets. Examine the patient's mouth and throat for redness and blistering or edema right from ingestion. And treatment for plant poisoning, you got to call the Poison Control Center. They have very specific things. Mushroom poisoning, we get the wrong kind, accidental ingestions, mostly because of kids get the accidental ingestions. Toxic mushrooms there's 7 different classes of them. So some of the ones you'll see in your, you see here the Amanita mushroom. You can see here the Amanita and Galerina belong to the deadly group, and the Amanita accounts for 90% of all deaths, mostly from ingestion. They're very toxic to the liver, so you see a mushroom like this. This is one of the ones you sure definitely do not want to be eating. Okay, so this shows you that 90% of the time people die from this mushroom right here when we have that kind of poisoning. Okay, signs and symptoms of poisonous plant ingestion, okay? Excessive salivation. So here we got some of that sludge stuff all going on again here. So you have the same type of symptoms that you have with sludge. And decreasing levels of consciousness and coma if it gets to that point. So you can see it's very dangerous. General principles of management. Protect the rescue personnel. Make sure you do not get any of that organism around you or somehow ingested to you. Patient, take them out of the area of repeated injection or wherever. If it's injected, we're starting with injection type of things when you have it. Poisonous plant ingestion, and then we have injected principles for injected toxins. Like for wasps, hornets, or any type of stinging type of animals. Injected toxins. Protect yourself first. Make sure you don't walk into the to the den or wherever that you're going to be pulling somebody out of. Identify the insect or reptile or animal causes, hopefully if you can. If you can bring it to the emergency room, I'm thinking probably pretty much, I'm not bringing that in, but maybe you can call some of the local type of animal agencies might be able to do this for you if it's an animal or reptile or something. Do your primary assessment, rapid physical exam, prevent or delay any further absorption of that poison. So give them some supportive measures, treat the anaphylaxis if there's any of that, transport as rapidly as possible to the control center, local protocols, and from there. Many people die from the allergic reaction from stings, pretty much known as the Hymenoptera. So those basically are common honeybees that leave the stinger in. But the other things like wasps and yellow jackets and hornets, they can keep stinging you over and over and over again. So that's the problem with them. Even if you're only encountering one of them, he could sting you several times like a wasp can and stuff. So that's unfortunate, but that can happen. It depends how allergic you are to it and where you are with that. Signs of localized pain, redness, and swelling. You see a big wheal on your skin at the location of it. You see like a little puncture wound, possibly even in it. Itching and flushing, tachycardia, hypotension, bronchospasm, laryngeal. Now you're starting to get into anaphylaxis and anaphylactic shock when you start having the last two lines here, and facial edema, uvular swelling. Now you're in big trouble, and you need to treat anaphylaxis very quickly. IM, epinephrine, or IV. Wash the area. Remove the stinger if it's just a yellow jacket. Try to scrape it without squeezing the venom sac. All right, if the bee's still on there. Cool compress, that'll slow things down, and observe and treat for allergic and anaphylaxis. African honeybees, or killer bees, or whatever you want to call them, they viciously attack stray into their territory, so it's very territorial, but you have numerous bee stings because they attack you as groups. So that's what happens with it. It happens, and that's why they're so deadly, because they attack in groups and packs like that when you get too close. You need protective gear as well as proper fitting bee veil. Immobilize and kill the bees with a whiting agent like surfactants and stuff. This is what they look like. They look pretty much like any kind of other honeybee. How do you tell? It's hard to tell. Brown recluse. We do have brown recluse in this area, so that'd be something you would have to worry about. All right. So there's a violin-shaped marking on the back. So it might call it a fiddleback spider, something like that. But, they're like 15 millimeters long. All right. So millimeter, it's not very long, but about 15 millimeters long. And you notice this kind of a pattern on it. That's what you see. You see that pattern there. You can kind of see the pattern here, and you can see it here also in a recluse. They have 6 eyes if you're going to get that close instead of 8. But it's that marking that you're going to notice it by. It's usually a painless bite. You get a small red spot surrounded by a white ring forms at the site. In the next 8 hours, you have local pain or redness, tissue necrosis at the site, and over days to 2 weeks. And eventually you might get into chills, fever, nausea, vomiting, joint pain, bleeding disorders. So, once you start having some of the initial symptoms, if you feel like you got beat, you see some of that localized pain, redness, and swelling, tissue necrosis, you start thinking, man, oh man, I need to get that looked at and not wait too long for it. So you'll see this kind of configuration. You notice the spread, how the redness spreads around the area. So it started here with that small macular area and erythema here, and you can see, look at the spread of the redness as it goes on for days. So you've got to make sure that you got something like that, and it's starting to spread and get hard and lump out and keep spreading out and out. You need to have that looked at quickly. That would make me think of a brown recluse for sure. Black widows, they can live in all parts of the continental United States, believe it or not. I don't ever hear of anything around here. But look at wood piles or brush. Female is the one that's responsible for the bites and the sickness. Well, that makes sense. Sorry, girls. Had to throw one in there on you. But here's the real striking marking is that orange hourglass marking on the abdomen, on a black abdomen. All right, I think, yeah, there's a picture of it right there. So it's kind of an hourglass figure, but look, it's very, very, very easy to see that. So very potent. It causes excessive neurotransmitters to be released. So it really screws up your neurotransmission. Excessive amounts. Immediate localized pain, regulating, and swellness, of course. Progressive muscle spasms of large muscle groups can occur with severe pain. Man, look at that. What that can do to us. Here's the back view and the other side view. Once again, here's the picture of it a little bit more. Nausea, vomiting, sweating, seizures, paralysis continues. So you see some of these neuromuscular type of problems starting to occur here. An anti-venom is available, so you need to go to some place that has that available as quickly as possible. Scorpions sting, localized pain. The bark scorpion is the one that's responsible for fatality. So a lot of these are just a pain for us, and they hurt and all that, but there is one that can cause fatalities. They move mostly at night, hide under a lot of debris and buildings and so forth. All the venom's right at the end of their tail, and that little bulb at the end of their tail. They will sting with the tail and inject small amounts of the poison. So you can see their structure here. Everybody pretty much knows what scorpions look like. And this is up here. This is this bulb up here, this large bulb where the stinger's at down here. That's where the poison's at. Its venom is a nervous system problem, so it produces burning and tingling throughout. The numbness, slurred speech, restless, muscle twitching, it progresses into some of that. It could actually go into seizures eventually. So you want to put a constricting band above the wound site, no tighter than a watch band to include lymphatic flow only. Avoid using any kind of painkillers, and there is an anti-venom available, but you have to get to a poison control center once again to take care of that. Snake bites. Depends on the state, where you're at, location of the bite, and the amount of venom. Common pit vipers like cottonmouths, water moccasins, we do have them around here. We may have some rattlesnakes or copperheads around the area too, in the wooded area, so you have to be careful. We might have some of those in this area. Here's a cottonmouth. You can't really see their mouths open up there, and it's all extremely white. But you look at the viper head, and it has that kind of triangle-shaped head, and that really kind of tips you off. Rattlesnake also has more of a triangle-shaped head, and you see this kind of markings. But some of the snakes around here have markings similar to that, but they're not rattlesnakes. They don't have that head or those fangs. Here's a copperhead, and you might see them in wooded areas. I know down in North Carolina, they're all over the place. I know probably up in Michigan. I'm sure we have copperheads around here. I'm sure there's some reports of those around in the Ohio area. So they have a distinctive pit between their eye and the nostril on each side of its head. So you can see that nostril on each side. That's why they're called pit vipers. They have elliptical pupils and 2 fangs, well-developed fangs and triangular-shaped heads. So that's what tips them off. There are rattlesnakes, and only the rattlesnakes has a rattle at the end of it. So like just the copperheads don't. See, there's no rattle there with a copperhead. Here's a rattlesnake, and they do have a rattle, and they have it. So you're not going to hear that with a copperhead or a water moccasin. All right. Coral snakes are they have that real bright coloring. There's a coral snake. If you ever see one, that's pretty nasty. They're really very poisonous. They're a distant relative of the cobra. Small snakes, small fangs, round eyes, near head. That's what the yellow banded red and yellow bands and red around the body. That's what you're going to see. So we have to watch where you go on vacation, where those are going to be. Nowhere up here. You're going to see them down in Florida and places in the Gulf and so forth. There's a lot of non-poisonous snakes. We have king snakes. They're really big. They kind of look like other things. They look like rattlesnakes and stuff. So here's a mnemonic: red touch yellow, kill a fellow. Red touch black, venom lack. So they're trying to give you red touch yellow, kill a fellow. Red Red touches yellow here. See on this coral snake, red touch yellow, kills the fellow. Where red touches black. So if the red and the black were back to back, they're not venomous. Okay? That's all that's about. Okay, so all right. The viper's venom contains hydrolytic enzymes and destroys proteins and tissue components. So it's hydrolytic. Infarction and tissue necrosis at the site of the bite, especially. So man, you're going to start seeing black. It's going to turn black. Severe bite, death from shock in 30 minutes. Most deaths are 6 to 30 hours after a bite. 90% within the first 48 hours are going to, if they're going to die from it, you're going to die in the first 48 hours. So, pretty intense. They can really screw you up. You're going to have fang marks. You're going to have 2 puncture wounds. You're going to have swelling and pain at the site. Continued oozing. You start getting weak and dizzy and faint. Sweating, chills, and thirst. Nausea, vomiting, because we got poison. We're trying to get rid of it. Poisons. That's why you have nausea, vomiting, and diarrhea. Tachycardia going into hypotension. Bloody urine. It's all that. It's all fiber. It's all lytic, right? In late stages. Bruising all over. Necrosis, especially at the site. Shallow respirations to respiratory failure. Numbness and tingling around the face and head is a classic symptom. So any of those pit vipers, you get down to this point, yeah. So that numbness and tingling around the face and head, man, that's big. So that's a big clue for a viper bite, like a cottonmouth or a copperhead or rattlesnake. We want to slow down the absorption. That's what we want to try to do. 25% of the bites are dry with no venom injected. So not every one of them inject venom right away. The amount of venom varies significantly as the degree does. Anti-venom considered only for severe cases. We start getting some other things. So keep the patient down, supine, immobilize the limb with a splint. Maintain extremity in a neutral position, not above or below anywhere. Do not apply constricting bands. Initiate supportive care. Provide supplemental O2 if they're hypoxic, and start IVs with crystalloid fluids. Take them to an ER for administration of the antivenom. Do not put on ice packs or to cool the wound. Do not apply arterial tourniquet. Do not apply electrical stimulation of any device in attempt to retard or reverses. So really, they don't want you to do any of the things you think about doing, or the guys on TV you see get bit by a rattlesnake. Don't suck the poison out. Don't put a tourniquet on it. Don't elevate it. Don't stimulate it electrically anyway. Don't put any cold on it to slow it down. Don't do that. All right? So that's a different thing than you're thinking of. It's almost everything you don't think you should do for a bite from one of those kind of snakes. Coral snakes also have a neurotoxin. All right? Classic severe bite results in respiratory and skeletal paralysis. This is why these are nasty. You might not see any effects of this for 12 to 24 hours. Nothing even locally where the bite's at. Local numbness, weakness, and drowsing, ataxia, slurred speech, excessive salivation, paralysis of the tongue and larynx. So then we're going to have trouble swallowing here, and also protecting your trachea when you swallow, because that's going to affect your uvula and stuff. So you're going to have to probably take airway control. Drooping eyelids, dilated pupils, abdominal pain, seizures, respiratory failure, hypertension, loss of consciousness. What are we going to do if we have a coral snake? Wash the wound with copious amounts of water. Apply a compression bandage and keep the extremity elevated at the keep the extremity at the level of the heart. Immobilize the limb to reduce movement. Start IV with crystalloids. So they do want compression bandage on these after you clean it and wash it with copious amounts of water. So here's what not to do. Do not put on ice. Do not incise the wound. So don't cut the wound to make it bleed out. Do not apply any stimulation device. Okay? Almost the same kind of things you do not do, except put the compression band on. It's the only thing different. So I would do that for coral snake bite because it's a neurotoxin versus the other viper bite. Marine animal injections, pains proportion to size of the injury. So the pain, you have a little spiny, little typey, sting, and it's just pain out of proportion. That's your clue in right there. If you get stung by a jellyfish, plus you're going to know that. Or like a spiny fish or a puffer fish, they all have those kind of stinging sea urchins. They look like those little spindle, like a circle with a bunch of spindles sticking out of it. They have injections also. They're very unstable and heat sensitive. Heat will relieve pain and inactivate. So we want to get them in. You want to warm them up and inactivate this stuff. So put maybe a warm compress on it. They're both freshwater and saltwater. You can have both of these. Can get some of these from freshwater and saltwater animals. They also contain a lot of bacterial and viral pollution, so that's a secondary infection when you get an injection in these different areas because it's just the waters you're in. So a lot of pain, intense pain out of proportion, remember, at the local site. Weakness, nausea, vomiting, little shortness of breath and tachycardia. In severe cases, they may actually go into shock, so it depends on the person and then how much venom and how many times they were stung. Airway, breathing, circulation. You can, on these now, they do want you to go ahead, marine animal injection. Now you can put a constricting band between the wound and the heart. No tighter than a watch band. Only to include lymphatic flow, not arterial and venous flow. Apply heat or hot water. So constricting band and heat, and keep air and inactivate or remove any of the stingers. Okay. So that's different than the bites from the vipers and the coral snake. They want you to do that for these things. Okay. Okay. We're going to skip through this. And at this point, I think we're going to stop and go into substance abuse and overdose on Wednesday.